Hey everyone, so you're getting ready to tackle Chapter 46 on urology? Perfect. You are in exactly the right spot. We're going to break down all the key vocabulary you absolutely need to know so you can walk into that lecture feeling totally confident and ready to go.
You know, it's so true that learning medicine is like learning a whole new language. And mastering these terms, it's not just about acing a test. It's about being able to listen to your patient, hear what they're saying, and know exactly what's going on inside. That right there is the key to confident practice. So, you ready? Let's dive in.
Okay, so here's our game plan. First, we'll nail down the core language. Then, we'll look at what happens when things kind of go sideways. We're going to decode symptoms, follow an infection from start to finish, and wrap up with the interventions you'll actually see out there. It's a super logical path from the basics to the more complex stuff.
All right, let's get started. First things first, we gotta lay the groundwork. Before we can even talk about what goes wrong, we need the right word for the normal, everyday process this whole system is built on.
And that word is micturition. Yeah, I know, it sounds a little fancy, but all it means is the normal act of urinating or voiding. This is your first real step into speaking the professional language. Your patient's gonna say, I have to pee, right? But in your notes, in your documentation, you're gonna write about micturition. It's all about that clinical precision.
Okay, so micturition is what's supposed to happen. That's the ideal. But what happens when that process breaks down? Well, that leads us right into the two most fundamental, most common problems you're going to run into.
So check this out. These are really just two sides of the very same coin. On one hand, you've got urinary retention. Basically, the bladder just can't empty all the way. It's holding on to too much urine. And on the flip side, there's urinary incontinence, or UI, which is the exact opposite, that involuntary loss of urine. It's a loss of control. The easiest way to remember it? Can't go versus can't stop. So if a patient has incontinence, what can we do? Well, one of the very first things we turn to, a totally non-invasive therapy, is pelvic floor muscle training. You've probably heard of these exercises as Kegels, and that's exactly what they are. It's all about strengthening those key muscles that are responsible for control, which can help patients get a handle on, or sometimes even totally resolve, their incontinence.
All right, so we've got the basics down. Normal function and the big problems. Now, let's get into the detective work. We're going to learn the language for the clues. You know, the symptoms your patient tells you about, and the findings you're going to see on their lab reports.
Okay, pro tip here. You are going to see this ending, this suffix, urea, all the time. It just means something to do with urine. So the real trick, the hack, is to just learn the prefixes. Dis, hema, protein, bacteria. Once you get those down, you can pretty much decode any term you'll see on a lab report. It's a game changer.
Let's start with an easy one, dysuria. That prefix dys always means something is painful, difficult, or just abnormal. So dysuria, it's a classic textbook sign of a UTI. It's your patient telling you, flat out, it hurts when I pee.
Next up is hematuria. You probably know this one already. Hema means blood. So this is simply blood in the urine. And it doesn't matter if the patient can see it or if it's microscopic, something you only find in the lab. Hematuria is always a big deal, a sign that something needs to be investigated further, for sure.
This leads us to a really important diagnostic measurement, post-void residual, or PVR for short. Think about it. After a patient voids, we need to know, did they actually empty their bladder? The PVR tells us exactly that. It's the amount, the volume, of urine left inside. And you can see how this ties right back to that idea of urinary retention we talked about.
So the big question is, how much is too much? What's the magic number? Well, generally, a PVR over 100 milliliters, that's when we start paying attention. That's considered clinically significant. That number is a clear signal that the bladder isn't working efficiently, and it gives you a solid piece of data to work with when you're planning their care.
Okay, for this next part, let's actually tell a story. We're going to follow the path of a UTI as it starts out as a simple local problem and see how it can escalate into something much, much more serious, a systemic condition. Understanding this progression is absolutely critical. So, where does our story begin? It usually starts right here with cystitis. Remember that ending, itis, just means inflammation of. So cystitis is an inflammation of the bladder. Just think of it as an infection that's stuck in the body's storage tank. This is your classic, run-of-the-mill, uncomplicated UTI. But what if that infection doesn't get treated? Well, those bacteria can start to travel. They can climb or ascend up the ureters. Those are the pipes that connect the bladder to the kidneys. And once that infection reaches the kidneys, that's when you get pyelonephritis. Now we're talking about a much more serious infection, an infection of the kidney itself. And trust me, these patients are usually pretty sick.
And this is the worst case scenario. This is the final chapter of our story. If that pyelonephritis isn't stopped, the bacteria can actually escape the kidneys and get into the bloodstream. That is bacteremia. And at this point, it's no longer just a urinary problem. That local infection has gone systemic. It's now a body-wide and, yes, potentially life-threatening condition.
Okay, quick but super important note. You have to know this acronym, CAUTI. It stands for Catheter-Associated Urinary Tract Infection. I promise you, you will hear this constantly. Why? Because preventing CAUTIs is a massive part of your job. It's one of the most common healthcare-associated infections out there, but it's also one of the most preventable.
All right, we're in the home stretch. We've covered the problems, the symptoms, how an infection can escalate. So for our final section, let's look at the toolkit. What do we actually do when the normal pathway for urine just isn't an option anymore?
The big idea here is something called urinary diversion. That's all these are, different ways to create a new path for urine to get out when the normal route is blocked. You've got catheterization, which is the most common, right? Just a tube through the urethra. Then a suprapubic catheter is a more direct line, going through the abdomen straight into the bladder. And what if the problem is higher up? Well, a nephrostomy drains the kidney directly. A ureterostomy actually reroutes the ureter. See? It's just 4 different tools for problems at 4 different levels of the system.
And there you have it. That's our quick tour of the essential urology terms you need to know. We've really built a solid foundation here. So I want to leave you with this question. You don't just know a bunch of new words now. You have a new framework for understanding what's going on with your patients. So, how is this new language going to change the way you listen, the way you interpret, and ultimately, the way you care for them?